So evening, everybody. Thank you very much for joining us. My name's Fiona LeBroy from Heartburn Cancer UK. I'd just like to introduce you to my colleague Jess, who's been organising you all to join this evening, and a very warm welcome to Sheraz Markar, who is Professor of Upper Gastrointestinal Surgery at University of Oxford. And I'm sure Sheraz will correct me got that if I've got that wrong. He's also one of our HC UK trustees, and newly appointed surgical specialist lead at the Royal College of Surgeons. So really delighted to have Sheraz join us this evening to help give us this talk. So this evening we're talking about hiatus hernia. We'll be talking, or Sheraz will be telling you, about symptoms, diagnosis, treatments, and he may well touch on research as well if we've got some time. There will be an opportunity to ask questions, so we can make the session interactive at times if you've got anything that you want to ask. If we run out of time at the end, if there are any other questions, we'll try and then answer them after today. And just in terms of a little bit of housekeeping, if we can make sure that we're all on silent, and if you do want to ask any questions, if you can either raise your hand or pop them in the chat, and we'll try and get to you at the most convenient moment. Jess, have I missed anything?
I don't think so.
No. Okay, thank you. Sheraz, over to you.
Brilliant. So thank you very much to Fiona and Jess for the invitation to talk today. I'm just going to try and share my slides. Hopefully that will work. Can you see that okay? Yeah, brilliant. So look, I'm trying to keep this as quite as light as possible in many ways, and just trying to give you really sort of a window into how we sort of think about hiatus hernia, in both in terms of the symptoms that patients present with, but also how we diagnose it and we work up patients for consideration of surgery. And then really some of the nuances around surgery, because you'll talk to surgeons potentially about having this kind of hernia repaired. And I think it's important for patients to start to really be educated around, potential options with surgery, so they can talk in a realistic fashion to their operating surgeons. So these are my disclosures. So there are sort of three main things I want to talk about in this discussion. And as I said, my slides are light. So the idea is really trying to create as much discussion as possible. So if you have any questions, I can't see them here. So Fiona or Jess will stop me and just jump in and let us know. So first is I'm going to talk to you about really what is a hiatus hernia. Then secondly, I'll talk to you about really what symptoms does it actually cause. And then finally, I'll talk to you about really how we repair it and that kind of pathway, and potentially what you can really expect from surgery and really the outcomes that we see with surgery down the line. My main disclosure is that I am a practicing esophagogastric surgeon. So I do a hiatus hernia, but I also do a lot of cancer surgery as well as part of my practice as well. So there are, when we talk about a paraesophageal or hiatus hernia, we're basically talking about four main types of hernia, basically, and they're really outlined here. And essentially, the diagram A reflects your normal anatomy, which is you have your gullet and your food comes down your gullet and it hits your stomach, which sits mainly in your abdomen. And then the food is mixed up with all the acid and all the other enzymes in your stomach and then travels into the small bowel. That's normal anatomy. What we talk about sometimes is a type 1 hiatus hernia, and that's really a relatively small hernia. So basically, it's where this junction between the gullet and the stomach has slipped into the chest. And patients typically would present with symptoms of reflux with this type of hernia, because you basically end up with a pressure differential between your stomach and your esophagus. So the acid, which should sit inside your stomach, sometimes refluxes back up. And when we talk about small hiatus hernias, that's really what we're talking about with a type 1 or sliding hiatus hernia. A type 2 hiatus hernia is another type of hiatus hernia, but it's where the top part of the stomach, so the fundus of the stomach, the uppermost part is sort of slipped in parallel to the esophagus. So the junction between the gullet and the stomach sits below the diaphragm, but part of the stomach has just popped up into the chest. Not a huge amount, but typically a small amount, typically less than 5 centimeters of stomach is in the chest. Now, that will also cause symptoms of reflux, but you may get some other symptoms associated with that, such as regurgitation or pain, actually, in some patients. And then the third type of hiatus hernia is whereby most of the stomach is sitting in the chest. So both the junction between the gullet and the stomach, and also some of the stomach is sitting in the chest. So typically more than 50% of the stomach sitting in the chest. And what we call it with that is we typically call that a giant paraesophageal hernia, if it's more than 50% of the stomach sitting in the chest. And really, patients will present, as you can imagine, with reflux, but they also present with sometimes difficulty with swallowing, sometimes pain on swallowing, and sometimes vomiting as well. In those kind of cases, it's your type 3 hernias which can present as in an emergency situation, whereby the stomach is sort of stuck in the chest and it's not coming down and it's causing severe pain. And in those situations, we worry about, blood supply to the stomach in an emergency setting. And then the last type of hiatus hernia is a type 4, where another organ has herniated with the stomach. So it can be the small bowel or the colon, or sometimes the pancreas as well can go up, or rarely the spleen, but also the spleen in some situations can go up as well. And as you can see, what happens is that this sort of solid brown line is meant to represent the diaphragm. This whole of the diaphragm gets progressively larger as the size of the hiatus hernia gets bigger and bigger. Okay. Are there any questions on that? No? All right. So I'll keep going. So essentially, one of the main things is we try to work out with when we see patients in clinic is what symptoms are attributable to the hiatus hernia. So typical symptoms would be things like reflux or heartburn, as I talked to you about with small size hiatus hernia. Other things people get is regurgitation, as we talked about, or difficulty or pain on swallowing. And patients also sometimes get chest pain associated with the hiatus hernia. More rarely, people do present with things like shortness of breath or anemia. The reason why people present with shortness of breath is with a large paraesophageal hernia, like a type 3 hernia. If you can imagine, there's most of your stomach in your chest, and it takes up a lot of the capacity that your lungs should have to breathe normally. So you get a pressure effect, basically, in many ways. The other thing that people sometimes you can get erosions of the stomach called Cameron erosions, which can bleed from time to time. And that's really the point when the stomach passes through the diaphragm, and it's sort of a scratching on the stomach, basically causing it from bleeding, causing ulcers, which can cause it to bleed from time to time. And that forms, that can cause anemia in some patients, and can cause lethargy and things like that, which you would expect with a hiatus hernia. Or a giant paraesophageal hernia as well. And I wrote a paper a few years ago, basically, around this, because I wanted to really look at the published literature and really look at what are the symptoms associated with large paraesophageal hernias. And basically what we showed was that there's a whole host of symptoms, but if you look at the pie chart, really a lot of these symptoms are gastrointestinal, as you would expect, but also symptoms such as nausea, vomiting, and reflux are very common, but also patients present with pain, and a fair number of patients are presenting with this shortness of breath or bleeding, as I talked about, with anemia, or sometimes with blood in the stool in many ways, or melena in terms of dark blood as well. One of the things that I personally, my area of research in many ways was around quality of life and symptoms patients that have. And one of the things that I found amazing with paraesophageal hernia is that I showed there's a whole host of symptoms that patients present with, but in actual fact, we use the same, largely speaking, we use one quality of life tool, which is GERD, health-related quality of life, which is primarily focused on just identifying patients who have reflux. That's what it's really focused upon. So whilst we can talk about all of these other symptoms patients have with paraesophageal hernia, in actual fact, we're really only focusing on reflux when we try to evaluate outcomes from surgery. So this led to some work whereby I became more interested in it, and we went through a sort of consensus process, and we developed a new tool which is really focused around just paraesophageal hernia and the symptoms. So really what we focused upon with this is, yes, we capture heartburn and reflux, as does the other tool, but we also captured feelings such as difficulty in getting solid food down, difficulty in getting liquids down, chest pain after meals, shortness of pain after meals, an early feeling of fullness or what we call satiety for patients. And we're able to grade these upon basically how often they occur for a patient, and also how much they feel that this is impacting their quality of life. So this tool now will be implemented in the UK in a national study, whereby we will collect this data for patients both before and after surgery in a longitudinal fashion to really understand how patients' symptoms evolve with potentially surgical treatment. So that's in many ways, quite interesting, hopefully down the line. Any questions on any of that? No? Okay. I can keep going. So I always talk about mentors. I think mentors are really important in surgery. And so for me, I had sort of 3 great mentors in my career. The first in the white coat, as you can imagine, as an American surgeon was Don Lowe. And he, in many ways, taught me a lot about paraesophageal hernia. He did a lot of paraesophageal hernias in Seattle when I worked for him as a fellow. And really what he talked a lot about was a specific type of operation called the heel repair, which I'll touch on, but is not something commonly practiced in most centers in the UK. The second was Nick Maynard, who was, again, my long-term mentor and really is my colleague now in Oxford. And Nick is very focused on the symptoms that patients have and also really looking at revisional surgery for paraesophageal hernia or hiatal hernia. And then finally is George Hanna at the bottom, who was my academic mentor. And largely speaking, George taught me a lot about cancer surgery, but also did touch on a lot about really how we can develop robust quality of life tools for patients. And that's really where we came with the post-study in many ways. So I think when we talk about, when I see a patient in my clinic, really the crux of it comes down to the history of the patient. More than anything else is I really need to identify in my mind what the dominant symptom the patient has is. Just before we started this call, we were talking about how patients are becoming more and more common with the diagnosis of paraesophageal hernia or hiatal hernia. And this is really because patients are having CT scans for so many more indications than normal, and you pick up an incidental finding of a hiatal hernia or a paraesophageal hernia. The question then is what do you do about it? And it really comes down to, does the patient have symptoms or not? And how big is the hernia? So in my mind, the history is absolutely key to identify the dominant symptom of the patient and also to establish whether or not they are on any medical therapy, like a proton pump inhibitor, for example, and whether or not that's making any benefit to their symptoms at all. Then typically patients will have 3 investigations before they have an anti-reflux operation or a paraesophageal hernia repair. The first is an upper GI endoscopy, and primarily, this is Heartburn Cancer UK, so the most important thing is to rule out cancer in these patients, but we're also looking for any inflammation of the esophagus caused by reflux, or really trying to document the size of the hiatal hernia, as we talked about. The second is that I'm very interested in doing barium swallows, and part of that is to give me a view from the outside to really look at the anatomy of the hiatus and really look at the size of the hernia, but also look at basically potentially the emptying of the stomach. So if the stomach doesn't empty very well, if it's sitting most of it in the chest, then that's a really good indication potentially to operate on the patient, because the patient may have symptoms of difficulty swallowing and their stomach is emptying well. So therefore that patient's going to run into trouble down the line. And the other thing that we really study in patients with small hiatal hernias really mainly is patients who have reflux, and what we call pH manometries, whereby we look at the correlation between essentially how much acid a patient says they're having symptomatically versus an objective test, which is basically with a pH probe sitting at the bottom of your gullet, how often the patient is actually objectively experiencing reflux. And the second aspect we get from that is also motility. So basically, how well does your lower esophagus actually contract? And that becomes important when we start to think about the operation, which I'll talk about in a second as well. So, sorry, this slide is not very nice, but essentially this was a Delphi consensus of multiple international surgeons across Europe. And essentially it came down to that most surgeons, before a patient undergoes hiatal hernia, are performing 3 tests. One is an endoscopy, the second is a CT scan, and the third is contrast imaging, which is a barium swallow, as we talked about. So if you're a patient and you come to see a surgeon, you are most likely going to have those 3 investigations and maybe pH manometry before you have a hiatal hernia repair. So it's just to prepare yourself that that's most likely going to be the workup for most surgeons. So there are 3 main components to an operation when we talk about it, and really I think it's important for patients that when they see their surgeon is to understand that the surgeon will vary their practice, and it will vary from surgeon to surgeon, and the evidence is there. But I'll talk to you about some of the limitations we have with the current evidence. So there are 3 main phases to this operation. The first is crural repair, which basically is you have a hole in the diaphragm. The question is it's like any hernia, right? So you have a hole in the diaphragm. How do you repair that hole whilst maintaining enough space for the esophagus to sit there and enough food to go down, basically? So how do you make the hole smaller so that the stomach doesn't fly back up? The second is how do you fix the stomach inside the tummy so that it doesn't go back into the chest? That's basically the second principle. And then the third is should you try to strengthen the lower esophageal sphincter if that patient has reflux? Because if they have reflux, maybe that chronic period of time that the sphincter is sat in the chest means it's now weak. So in actual fact, should you be strengthening that the lower esophageal sphincter, or the junction between the stomach and the gullet, to make it a bit stronger to prevent reflux in the future, and also potentially to bulk up that area to prevent the stomach from going back up into the chest. So this slide is basically, I used to work in Karolinska, and one of the things that I think is really important is a lot of patients ask, surgery is an operation, right? So how safe is this operation we're talking about, basically, for patients? So essentially, this is a very large study. It was conducted in sort of over 26,000 patients, and the mortality rate from hiatal hernia is very low. So it's 0.08%. To put it into context, the mortality rate from esophagectomy or gastrectomy, which is a cancer operation, which I do in the UK, currently sits at 1.3%. So, basically substantially higher than what we see with anti-reflux surgery. The 90-day reoperation rate is 3%, and this is in a very large series of patients conducted across Scandinavia. The other thing I'm often asked with patients who have, say, a very small paraesophageal hernia, say a 2-centimeter hiatal hernia, and they say, okay, what's the evidence of having surgery versus having just medical therapy? So we in the UK conducted one of the largest trials ever conducted, which was called the reflux trial, where we randomized patients who had reflux with a very small hiatal hernia, so less than 2 centimeters, to either having surgery or having best medical therapy. And we showed in a randomized control trial that at 5 years, patients' reflux control is better with having an operation compared to best medical therapy. In patients who are fit to have an operation is one thing. And secondly, these are patients who have small hiatal hernias, just to clarify. So that's great in a randomized controlled trial, but patients often ask me, okay, so if I have a hiatal hernia repair, or if I have an anti-reflux operation, what's the chance of me needing another operation? And this is a national study. So I conducted a national cohort study a few years ago now, 2020. Time has really passed. But anyway, basically whereby we looked at, with a median follow-up of 6 years, if you have an anti-reflux operation, your chance of needing another anti-reflux operation within that 6 years is around 9.4%. And importantly, if you say to a patient, and I really believe this, and I think it's really important to counsel patients properly. So if a patient is trying to get off their proton pump inhibitor entirely, it's important, if a patient's on a very high dose, say, for example, they're taking 40 milligrams of omeprazole twice a day, it's very unlikely at 6 years that patient will be completely off their PPI. We know that only 60% of patients will go back onto their PPI within 6 years of surgery. Okay. Now they won't go on to the same dose of proton pump inhibitor, but they will go on to some proton pump inhibitor. So it may be that you started on 40 milligrams twice a day and you may end up on 20 milligrams once a day. But it's important for patients who want to come off their medical therapy completely for them to understand that only 40% of patients at 6 years are still off their PPI at after surgery. So it's not a cure by any means for patients to get off their proton pump inhibitor. Are there any questions before I move on to sort of the nitty-gritty of surgery?
Yeah, we do have a question, actually. Glad to see the chat's working. Kat has asked, with a small hernia, is there an alternative to taking PPIs, and is it possible to reverse the hernia without surgery?
So, so with a very small hernia, the answer is no. It's an anatomical defect. It won't reverse, but what it will do is it may just stay the same size. So it may be one of these things whereby it stays with you forever. And if it's minimally symptomatic, i.e. if you don't have many symptoms and say you're on low dose proton pump inhibitor, I think it's very reasonable to stick with that. If you want to try to get off your medical therapy at that stage, then yes, an anti-reflux operation is a very reasonable thing to consider. But outside of that, no. That people do. There are new techniques like endoscopic fundoplication, whereby you go down with a endoscope, flexible endoscope, like when you have an upper GI endoscopy for cancer, and you can do it from inside. But I would say that there's only a handful of centres, maybe 2 in the UK, who are currently performing this in sufficient numbers to be considered acceptable, in my opinion.
Okay, there's another one there. Oh, there's another 2. We might as well just take a moment if that's okay. Kate is wondering, did those patients, the 40% who didn't go back onto a PPI after surgery, have any common features, age, weight, size of hernia?
So yes, they tended to be, I think they were in the 50 to 70 age group. Although, you know, that might be also an issue around follow-up, because for patients over 70, they may just drop out of regularly seeing their GP, is one thing to bear in mind. The second thing is a BMI is a big factor, without a doubt. So if your BMI is more than 35, your chance of failure from any surgical intervention is much higher.
Okay, thank you. And Lindsay is asking, what causes the hernia in the first place?
Yeah, great question. So no one honestly knows. I mean, what I would say is that there are some things like increased abdominal pressure associated with obesity is one of the risk factors, definitely. Other risk factors can be if you've had a hernia in your groin, for example. Some people do have people talk about different types of collagen, or different types of basically fibrous tissue in your muscle, basically. And they say that if you have a hernia in, you know, one area of your body, you are more likely to develop a hernia in another area of your body. And there is some, what I would describe as limited scientific evidence to support that. But there is a study currently ongoing in Europe where they're taking biopsies of the diaphragm and comparing it to muscle biopsies elsewhere in the body to look at different types of collagen, which I think is exciting, or interesting in many ways, to look at why patients may develop hernias.
Okay, thank you very much.
I've got another one here, actually. Also about a small hernia. How is it possible for reflux/acid without pain to come back out through nose, eyes, and back of throat?
So it can absolutely. So you can have reflux is a funny thing, isn't it? Because it sits there, and basically what you can have is you can have reflux going up, basically, and patients commonly talk about when they lie flat, it comes up through your, you know, through your nose, or commonly an acid taste at the back of your throat is where you feel it most commonly. The eyes is I think would be very unusual, but the nose is commonly affected, and I see a lot of patients in my clinic who have problems with their throat, commonly what we call acid brush at the back of the throat, and they've seen an ENT physician, and they've seen multiple people, and they end up basically then coming to see me, and then I scope them and see esophagitis or florid esophagitis through their esophagus, inflammation of the esophagus, and diagnose them as having just basically severe reflux.
Thank you. Jess, any more, or we carry on?
No more from me.
Okay.
All right. So, I'll try. I'm trying to keep this. I'll talk to you. Basically, I talked to a patient in clinic. As I talked about, there were three main components to this operation, and the first I'm going to deal with is the diaphragm, essentially. So, commonly when you see surgeons, they will talk to you about mesh versus no mesh. Okay. So what we mean by that is mesh is a prosthetic material, and it can be multiple different types of it. They can be permanent, they can be semi-permanent, they can be absorbable, completely absorbable, they can be biologic or non-biologic. And really what it comes down to is whether or not that mesh is, how well it's incorporated into the body or not. Okay. The second alternative to doing what we call a mesh repair, whereby we use this kind of prosthetic mesh, is just doing sutures. So simply repairing the diaphragm with, you know, interrupted sutures or continuous sutures, however you do it. So it's been a debate for, you know, I mean, basically since forever. I mean, I would say, in all honesty, it's been a massive debate amongst surgeons as to whether or not you should use mesh or not use mesh. Surgeons argue about it all the time. This is probably the best randomized control trial that I know from Sweden. And really what this showed was that if you look at the recurrence rate at 3 years between patients who had a mesh versus patients who just had sutures as the repair of the diaphragm, the recurrence rate sits at 13% versus 10%. So it's essentially equivalent, basically. So around 10, remember that figure in your mind that I said around 10% of patients would need a reoperation. So whether or not you repair the diaphragm with mesh or with sutures makes basically no difference to that. In the longer term. Now, there are some newer types of mesh which are coming out, and it's a constantly evolving field with companies working on trying to develop new types of mesh to try to reduce this. My honest disclosure is that I use primarily sutures as my default. And if the hernia looks very large or the defect is enormous and I'm very worried about the tension in the repair, then I may use specific types of mesh in those situations. But you know, it's vanishingly rare in my practice, but it's something that can be considered in patients whereby you're worried that the repair is under a lot of tension. But yes, it's something that you should ask your surgeon, because mesh is a foreign body. It's being placed very close to the esophagus. There is a risk that surgeons worry about, particularly with permanent mesh, that it can erode into the esophagus. And that's something we do worry about, and genuinely. Again, you know, surgeons will report their worst cases. So, you know, if you've ever seen a case of mesh eroding into the esophagus, you will never forget it. And it will scar you as a surgeon for your career, basically, in all honesty. So it's just something to ask your surgeon when you go and see them what they're planning to do with the diaphragm, and whether or not they do anything specific. When we talk about quality of life, when we talk about using mesh or no mesh, the important thing to really establish within this is that, in actual fact, this is the physical component of patients. And what we showed is that this is a randomized control trial, again, from Australia, whereby they probably have the largest series in many ways in the world for doing this type of surgery. And what they showed is that suture-only repair basically is the same as absorbable and non-absorbable mesh in terms of quality of life down the line. So using a mesh doesn't influence the quality of life in the longer term of patients after having this type of hernia surgery, based upon the most robust evidence that we have to date currently. I'll skip about fixation of the stomach because it goes with the wrap in a second, which I'll talk about now. So the second thing is, okay, so you've repaired your diaphragm now. So you pulled the stomach down, you mobilize the esophagus, and you've repaired your diaphragm. The question then is you've got your stomach sitting there. What do you do with it? Basically, essentially, that's the crux of this all. So this was a randomized control trial from Germany, and essentially. What they looked at was they looked at patients whereby they either just fixed the stomach and the abdomen, so I just stitched it to the diaphragm or stitched it to somewhere in the abdomen, or did they formally wrap the stomach around the esophagus in what we call a fundoplication. And what they showed was that in patients whereby they did a fundoplication, the long-term risk of reflux was lower, and it didn't affect any of the other quality of life metrics. So what I take away from this is that if a patient says to me, my dominant symptom, and it goes back to that history, so if my dominant symptom is reflux, then yes, pull down the stomach, and the patient should have some form of anti-reflux operation, whether that be a total fundoplication or a partial fundoplication, which I'll talk about in a second as well. So that's my take home from this in many ways. If the patient says to me, my main dominant symptom is that I can't eat, then I would say no. Like I would say, in actual fact, what I do is I pull the stomach down and I fix the stomach to make sure that the stomach doesn't go back up into the chest, and I repair the diaphragm properly. Oh, sorry. So there are many different ways of doing what we call a sphincter augmentation, or looking at this junction between the esophagus and the stomach. Okay, perhaps the most common is the operation A in the UK, which is whereby you wrap the fundus around the stomach and you stitch one side of the stomach to the other side of the stomach in what we call, it's called a Nissen fundoplication, named after the surgeon, but it's essentially a 360-degree posterior wrap. So don't get confused by medical terminology. It's very simple. Basically, what you've done is you're encasing the entire esophagus 360 degrees of the way around, and you're wrapping the stomach posteriorly around the esophagus. So there's the posterior aspect, and the anterior aspect is covered 360 degrees all the way around. That's all it means. Okay. The second is a toupee wrap, which is whereby you wrap the stomach around the esophagus, again posteriorly, but you don't cover the anterior part of the esophagus. You stitch the esophagus, you stitch the stomach to the esophagus on either side, so you leave the anterior part of the esophagus bare, and that's called a 270-degree posterior wrap, or a toupee. And really, toupee was again named after the surgeon, but essentially the idea here is that you are only wrapping 270 degrees of the esophagus, so you're leaving part of it bare in many ways. The third and the fourth are basically what we call anterior partials of partial wraps, basically. So this is a door fundoplication, and essentially it's an anterior type of wrap, either a 90-degree or less than or more than 90-degree type of wrap. So we reviewed all of the evidence. I did a consensus guideline with the European Association of Endoscopic Surgery, international consensus guideline with surgeons from North America as well, and Australia. And what I would say is, based upon the current evidence available, is a posterior partial fundoplication or an anterior 90-degree fundoplication probably has the best outcome for patients with reflux in this context. And that's because it has good reflux control, but also it reduces the other symptoms associated with the fundoplication, which are difficulty with swallowing. Because if you can imagine, with this wrap, you're encasing the esophagus in 360 degrees of the way around, which is fine because it's a good anti-reflux operation. It's very very good acid control, but you are potentially running the risk that the patient won't be able to swallow afterwards with dysphagia, potentially. And that's what this showed through reviewing all of the evidence, that there was a higher rate of dysphagia and difficulty with gas bloating afterwards. And this really is what this randomized control trial shows, which is that the rate of dysphagia seen with a posterior fundoplication, a full 360-degree fundoplication, is higher than that seen with a partial wrap. So a total versus a partial, the rate of dysphagia appears to be higher, and the reflux control is actually equivalent between the two. Based upon the evidence, currently randomized evidence, we would suggest partial wrap is probably better for patients with this pathology. Now, what I would say is, honestly, is that a lot of surgeons change their practice over time. So, you know, my own practice, to be brutally honest, is I trained with George Hanner in London, and we only did 360-degree Nissen wraps. I did it for everyone. Like, I did a giant parasoft hernia, pulled everything down, and then I just did a 360 wrap because it was what George did, and it's what he trained me to do. Then over time, when I started my consultant practice, I started thinking about the operation more, talking to more patients after I'd followed them up, talking to other surgeons. So now I take a really good history. And if the patient has, if their main symptom is not reflux, but is difficulty with swallowing, as I said, I pull the stomach down, I do an anterior wrap, so a gentle wrap over the top, just to fix the stomach in place. And I fix the stomach in multiple places and do a really good repair of the diaphragm, primarily with sutures, But as I said, if the defect in the diaphragm is very large, or the muscle is very weak, then I may use some form of mesh. I must say it's vanishingly rare. I've only ever used it once, ever, just as a disclosure, but some surgeons will swear by it, and that's fine. But it's just important to talk to your surgeon so you know what's going into your body and you know what's happening basically as part of this. And the honest truth is that I always use this quote with Michael Jordan commonly with surgeons, which is, you learn a lot from your practice as you go through your career, which is that you've lost many games, you may have some adverse outcomes associated with it, and the evidence is the evidence, but the evidence is a surgeon in Sweden or a surgeon in Australia performing this operation, and it may not be reflective of your own practice. So you have to bear that in mind. And also patients also have to understand when they talk to their surgeon, they may be talking with 20 years of experience in performing an operation. And perhaps the best thing is to be operated on by a surgeon who does an operation particularly very well in their hands. So just to conclude, I personally think patient selection is absolutely key for paraesophageal hernia. I think you have to be really careful about identifying what the dominant symptom of the patient is and what you're trying to achieve with an operation clearly in your own mind as an operating surgeon, and that makes your counseling of patients very important, because you're able to scale the expectation of patients to understand what symptoms you're going to help with and what symptoms you aren't going to help with. Investigations are key to really be able to identify which patients or which aspect of the symptoms are correlated with objective evidence, and therefore what you're going to target. As I said, counseling patients, in my opinion, is absolutely critical to the surgery, and scaling their expectations as to what is important. I haven't touched on this, but there are many devices on the market for reflux, and this may come up. I am running a trial at the moment called GOLF, which is randomizing patients between the links and fundoplication in patients with a less than 5 centimeter hiatal hernia. And I'm also running a trial in patients with very poor motility, randomizing them between best proton pump inhibitor and reflux stop, which is another device as well. And I'm director of a surgical trials unit, so and I am an upper GI surgeon. So I think that the problem we've had in the UK, in my opinion, is we haven't really robustly done randomized controlled trials in the past. So we are running 2 large-scale international randomized controlled trials now from Oxford, and one of the key aspects of that is that we are videoing every operation we do. So at the end of the trial, I'll say it's not just whether or not a surgeon did operation A or operation B, it's how well they did operation A or operation B, and also whether or not there are any technical errors or steps that may have been done a little bit better, which may have led to a better outcome for the patient. So then the idea is that then we can actually train surgeons to become better surgeons, or tailor their operation in a more meaningful fashion. So that's it. So I'll stop there, and I'm sort of very happy to take any questions after that. This is my team. This is my colleague, Richard Owen, operates with me all the time, and this is my trials unit. So thank you, and I'll take any questions.
Thanks, Sheraz. I've got a question on here from Kerry about what causes chronic throat clearing associated with reflux.
So a couple of things. One is that you can get true gastroesophageal reflux, absolutely, with it. So it's irritation of the back of the throat. So it's either acid coming up at the back of the throat. So people also sometimes get what we call laryngopharyngeal reflux as well, which is reflux right at the back of your throat as well. When you can also have with, as I showed with the type 3 hiatal hernia, you can have obstruction or partial obstruction to food and all the secretions from your esophagus going down into your stomach, and you can have intraesophageal reflux. So there are 3 main ways that you get this chronic, but it's basically irritation at the back of the throat, most commonly from acid refluxing back up.
Thank you. There was another one as well, just wasn't there?
Yeah.
From Lindsay, if you have Barrett's esophagus, should you have surgery?
Great question, really great question in actual fact. And I think it's something we don't honestly know. What I would say is that if you do have Barrett's esophagus, you are, obviously it's for those of you who don't know, Barrett's esophagus is a potentially pre-malignant condition that may lead to esophageal cancer down the line if untreated. So patients often go on to regular surveillance. The honest truth is we don't know. So I did the only national cohort study which looked at this in the UK, whereby we looked at whether or not if patients had symptomatic reflux and they had an anti-reflux operation, did it reduce the risk of cancer? And the answer was yes, but you needed to treat 50,000 patients to see it. So I think the change with anti-reflux surgery is very low. But what I would say is James Gossage from St. Thomas's, through my trials unit, again, is running a trial for patients with Barrett's esophagus called Linacra. And that trial is offering patients anti-reflux operation with the links who have Barrett's esophagus. So we hope to evaluate in that cohort of patients whether or not a links procedure reduces or potentially causes regression of Barrett's down the line, which I think is very exciting.
Sheraz, would you just summarize what links is, just in case there are some people that don't know?
So the links is a metallic device. It's a series of metallic beads around a magnet, which sits at the lower part of the esophagus. It's sort of in many ways, it's similar to the Nissen, so 360-degree wrap. The advantages in many ways is the operation is much more simple, so you don't have to do much mobilization of the stomach at all. And it potentially takes away the side effects that some patients have with anti-reflux surgery, including gas bloating, inability to belch, and so on and so forth. So that's the trial that we're running at the moment, which is comparing the links with fundoplication, which I think is actually very interesting down the line.
Brilliant, thank you. Jill's just asking, would you say this is an area where there has been considerable improvement and advances, or is it still slow progress?
So I think it's slow progress. If I'm being brutally honest, I really do. So I think it's an area whereby probably in the last five years, probably, I think people have started to really look at it in a lot of detail. And that's including myself. To be honest, because most of us become very interested in cancer surgery, so we focus upon that. But now we're starting to see a lot of patients in our clinic with reflux type symptoms and paraesophageal hernia. So that's why, you know, in my own trials unit, it's become an area of interest. In our trials unit, we've just taken over the National Hiatal Surgical Registry, so the National Benign Surgical Registry. So every patient undergoing anti-reflux surgery or paraesophageal hernia in the next, hopefully from June this year, will be recorded in a registry, and they'll be offered the opportunity to record their quality of life every 6 months for the next 5 years. So I think that's potentially interesting, because we'll be able to look at counselling patients, you know, who are coming up for surgery, to say what their quality of life looks like in 5 years' time in the UK.
Amazing. I've got a question as well. Can the stomach reset itself to stop producing so much acid to cause reflux if food, if food, in brackets, only water, is not consumed for several days?
So no. What I would say is that people do talk about using different types of diet to reduce the amount of acid, or to modify your diet in many ways, and that can help in some ways. If you have a large hiatal hernia, though, it's an anatomical issue. Like, you have an anatomical issue, you have an anatomical problem, because basically either the junction between the stomach and the gullet is sitting too high, or the stomach is sitting in the chest. Either way, that junction is not in the right position. So therefore, you have a pressure differential between your stomach, part of your stomach in your tummy, and part of your stomach in your chest, and that's causing reflux.
Thank you. There's a couple more. This is from Jane. I experienced periodic significant chest pain, which was my only symptom prior to an endoscopy, which revealed Barrett's and hiatus hernia. I'm still unclear what caused it, but it's not recurred since something of PPIs. Was it likely to be hernia related?
So it could have been hernia related, or it's very hard when you talk about reflux as quite a nebulous term. So reflux, when I talk about taking a very careful history, what I mean by that is asking patients, are they experiencing symptoms of acid? Do they feel like a bitter taste maybe at the back of their throat? Have they noticed a change in the taste of food and things, and these kind of things? Chest, like severe sharp chest pain, is can be related to hiatal hernia, sometimes in an emergency setting or in a short-term setting if it's very large in many ways. But most commonly with patients with Barrett's, they're experiencing reflux. They're not experiencing pain as such, but they can experience what we call esophageal spasm. So if you have Barrett's, it can cause sort of what we call scarring on the esophagus, so it maybe doesn't contract in a normal fashion, and patients then experience this kind of spasm type pain as their esophagus tries to contract against a part of the esophagus which isn't really working very well.
Okay, thank you. Lindsay's asking, and I'm sure we could do something about this, are we able to find out more about the trials? I'm not sure if you mean now, Lindsay, or maybe we can look at how we can get that information onto our website and summarize some of the different trials. Obviously, there'll be certain criteria, I imagine, and they won't be available to everybody, but we could certainly perhaps look to do that, could we, Sheraz?
Yeah, absolutely. So yeah, very much so, actually. So we have, obviously very not strict, but very, very important inclusion criteria and exclusion criteria for our trials. So I think that would probably be very helpful to share it with sites and share it with your website, but also the sites that are taking part in the trials is probably equally important. So you know where to go.
Yeah. So we know the geography as well. Yeah, but we can look at doing that.
Yeah,
Lindsay, that's a good question. Paula is saying, I was misdiagnosed Barrett's, have a 5 centimeter sliding hernia, terrible reflux, waiting nearly a year for review in Norfolk, suffer with regurgitation and feeling full. Oh, sounds like you're having a bit of time of it, Paula.
Yeah, she's also waiting for an operation lower down, she says, and she's been on PPIs for 20 years.
Yeah. I mean, look, I'm very sorry, basically, in all honesty. I think, unfortunately, the NHS is very stretched, as many of you obviously know at the current time. And the waiting lists for anti-reflux surgery in some areas of the country are extremely large and waiting a long time. Resources are very stretched at the moment. However, what I would say to caveat all of that is that people are trying to reduce their waiting lists by doing initiatives on the weekends as well. In Oxford, we are prioritizing patients with reflux and these type of symptoms for clinical trials, which helps us to get through the waiting list, which helps. And many of the centers participating in trials are prioritizing it as an area of surgery for them.
Thank you. Kat is asking, is it safe to take low dose PPIs long term?
Yes, it's a very common question. Yeah,
it is.
In all honesty, I would say low dose. I think the epidemiological data is out there, and no one knows. Like, I mean, the other thing as well is that you have to really think about. So when you read papers, like publications, and there's always a press release with it, and they say PPI linked to osteoporosis, or PPI linked to dementia, or PPI linked to cardiovascular disease. They've looked at a study in typically, over 500,000 patients to come up with a change in risk of less than 5%, basically, to see that. So that's really what we're talking about here. That's not to say that, if you're on very high dose proton pump inhibitor, that you aren't going to get osteoporosis, or you aren't going to get, any of the other problems I've talked about. But with a very low dose PPI, it is a safe, in my opinion, and this is my opinion, it's a very safe medical therapy to take. However, if you are concerned about it, I think by all means ask your GP to go and see a surgeon and have a discussion with them, because surgery isn't, perfect by any means. We take away the reflux in many ways, but we do leave you with potentially other symptoms, as we've talked about, such as gas bloating, inability to belch, sometimes some difficulty swallowing. So it's a trade-off, and it's important to have that conversation. But what I would encourage people to do, and I hope if you take nothing away from this, one of the things you do take away is, if you are suffering with severe reflux, by all means ask your GP to send you up to see a surgeon, because it's available and it's a treatment that we can offer.
Thank you. Kate's asking, what's the usual recovery time post-surgery?
So what I counsel my patients is typically it's keyhole surgery, so the recovery is pretty quick. See, it's 2 weeks. Realistically, you're on usually on a different type of diet, so softer type of food, and then you advance your diet sort of after that. Some procedures that like the links, for example, the recovery time is believed to be shorter. Again, that will be hopefully proved or disproved within my trial. What I would say, full disclosure, I have no industry, the industry aren't supporting the trial. This is a national NIHR funded trial for links versus fundification. So it's been viewed by, the government as an important trial of interest. And therefore, that's why the trial was funded to take place in the UK.
Thank you. Sue's saying 10 years post Nissen surgery, would you know why a hernia has now reoccurred together with significant reflux?
So as I sort of alluded to, at 6 years, around 10% of patients will have a reoperation. Honestly, what I would say is if you've made it to 10 years, that's not a terrible outcome from surgery in many ways. It's very rarely a permanent solution. So it does come back sometimes. And if you do have symptoms after that, revisional surgery is complicated and challenging, but by all means you should seek surgical intervention if you're having symptoms. And my colleague and myself here in Oxford, we do a lot of revisional surgery, and I think most surgeons around the country would be willing to consider it, and it's something that should be considered if you have a recurrent hernia and recurrent symptoms, definitely.
Thank you. Teresa's asking, are there a number of centres of excellence?
So no, that's the honest truth. So at the moment, we don't have that in the UK. So what we have is we have centralised esophageal and gastric cancer to centres of excellence. There are, I think, 26 in the country now, in the UK, in England, sorry. But anti-reflux surgery and paraesophageal hernia has never been centralised. What does happen, though, is that in an emergency setting, if a patient presents with, a obstructed paraesophageal hernia, that means where the hernia is stuck and the patient can't eat anything, or they are very unwell and we're worried about blood supply to the stomach, then that patient will be transferred to a cancer centre because the stomach may need to be removed in that context. And that's an emergency. So that would come to, so for example, in my area in Oxford, primary anti-reflux surgery, I take from mainly Oxford, but revisional anti-reflux surgery we take from across the region, and patients who present as an emergency, we take across the 10 hospitals or whatever in our region.
Thank you. Lindsay has said, thank you, Sheraz, you're appreciated, which I think is lovely. And Jane has said, thank you too, and Paula. And Lindsay has also said, I think, Lindsay, you must have had the surgery previously. She says, I struggle to belch now. My partner has to wind me. So I just thought that was one of those things that come with this, doesn't it?
Surgery.
No surgery.
No.
Okay.
Renata has also said, thank you so much, Sheraz, for this very interesting and informative presentation. It has helped me understand so much more about my hiatus hernia. So thank you.
Great. Good. I mean, I really think that it's just important that you really understand the patients really understand what symptoms they have, and they really speak to their surgeons about what the operation is trying to achieve. So I commonly see patients, and they present with sometimes a whole host of symptoms, and some of them may be diarrhea, for example, and I say, whilst I can fix hiatus hernia, it's not going to help with the diarrhea at all. So just to be very clear, you understand what this operation is trying to achieve and what it's not going to achieve.
Brilliant, thank you.
Yeah, fascinating.
Kerry said a big thank you too, just for giving up your time this evening.
That's fine. Thank you very much.
Lindsay just said, I was given the diagnosis but no follow-up, so thank you.
Okay. All right.
And Paula's going back to the doctors, which is good. And Kate says, thanks very much. Well, this has been really interesting. Thanks very much, Sheraz.
Thank you, everyone.
Yeah, it was really, I think it was really useful for Jess and I as well, actually. So thank you very much for that. Thank you all for joining this evening. If any of you have got any thoughts on other expert speaker talks, anything else you'd like us to try and organise and set up, please do drop us an email, and we'll try and arrange what we can for people. This was a particularly popular subject, and just remind me, we've got quite an interesting one coming up, which I'll just let you know about now, just in case it's of interest, from the Functional Gut Clinic, and it's Professor Anthony Hobson. Yeah,
it's on the website now, under our expert speaker page. I'm now trying to rapidly find what it's called again.
I've got it. Exploring role of gut bacteria and diet when reflux medication doesn't work. So that's really quite an interesting one as well. So just to let you know, that's coming up. I think it's, I want to say it's the 16th of, 16th of
April. Yeah.
Okay. So thank you all very much for joining. Thank you, Sheraz. Really appreciate that.
Thank you.
Thank you, everyone. Have a good evening.
Have a good evening, everyone.
Thanks, everyone. Thank you.
Thank you.